Are you ready? Okay. So we'll start the next session. The first lecture is going to be delivered by the Dr. Sailendra Singh from Hyderabad, India. And I am Dr. Shantaraj, Dr. Sailendra Singh. You can, I think, remember, I think you are the one helped us to start the PTMC program in Sri Lanka. Actually, when he started it in 1994, you came and stayed with us for 1 week and gave us the hands-on experience and to progress it. Thank you very much for that. And from that date, we have done large number of PTMCs, and I think you get the credit for helping us to initiate the PTMC program in Sri Lanka. And without introduction, can I ask you to proceed with your lecture on PTMC step by step? Silencing.
Good evening. Today we'll be discussing PTMC step by step. This is a procedure that has virtually replaced closed mitral commissurotomy and open mitral commissurotomy for patients with mitral stenosis. PTMV is recommended in all symptomatic patients with moderate mitral stenosis and all patients with severe MS, whether or not they are symptomatic. You require a favorable mitral valve anatomy. Mild or no MR, there should be no evidence of atrial thrombus to PTMC. Let us directly go to the technique. It is Innova balloon technique. Kanji Innova in 1984 developed the Innova balloon as a logical extension of closed mitral commissurotomy. Innova balloon catheter is made out of polyvinyl chloride, and the balloon has 2 latex layers with polyester mesh in between. So this is the picture of the Innova balloon or the Acura balloon. The only difference between Innova balloon and Acura balloon is to de-air the balloon. There is a vent in Innova balloon. In Acura balloon, there is no vent, and you have to de-air as you de-air any normal balloon. So the procedure starts with transeptal puncture. Transeptal puncture, you have to go from right atrium into the left atrium by puncturing the interatrial septum in the region of the fossa ovalis. Fossa ovalis is situated superior and posterior to the coronary sinus, and it is posterior and caudal to the aortic root. This anatomical position is very important. You start PTMC by puncturing the right femoral vein. Take a 032 wire, because the Mullins sheath and dilator doesn't take any wire above 3.2. So you take a 3.2 wire, and then you puncture the left femoral artery and put a pigtail and put it ideally in the non-coronary sinus of the aortic root. Then you advance the Mullins sheath and dilator into the SVC. Then take the wire and manipulate it to the left side. And then when you are on the left side, when you are coming down for transeptal puncture, it abuts along the septum. So septal puncture, you start with this. You take a broken burrow needle. Broken burrow needle is a 18 gauge needle, which tapers to 21 gauge at the tip. It is a 70 centimeter needle with a pointer at where your hand holds the needle. And the broken burrow needle should be put in the Mullins sheath, and the dilator should be just inside the tip of the Mullins dilator. And then you take the Mullins sheath and the dilator and come down with the whole assembly from the SVC toward the tricuspid valve. When you are coming down, it abuts the septum, and comes down the aortic root impression on the septum, and then below it engages in the limbic edge of the fossa ovalis. In the limbic edge of the fossa ovalis, you engage the whole assembly. That is, you advance the whole assembly so that it is engaged well. And if you are satisfied, you puncture the interatrial septum. So this is how the needle goes, and the needle is just inside the Mullins dilator tip. And then you come down the interatrial septum, come down along the interatrial septum, and when it is one space below the pigtail, Yeah, you are now one space below the pigtail, so you are in the fossa valis region. You advance the whole assembly and engage, and then turn to a lateral position. In the lateral view, the needle should be posterior to the pigtail and caudal to the pigtail. In that situation, you puncture. As soon as you puncture into the left atrium, you give a puff of contrast. Then you identify whether it is in LA. You can also, at the same time, record the pressure, left atrial pressure, or take an oxygen saturation there. But the best way is to give a puff of contrast. Once the needle is in the left atrium, you advance the Mullins dilator over the needle. Don't push the needle further because it might puncture the posterior wall of the left atrium. Advance the dilator. Once the dilator is inside the left atrium, take out the broken barrow needle and take the left atrial wire, that is the circular wire of the left atrium of mitral valvuloplasty, advance it into the LA and take out the Mullins sheath and the dilator. When you have done that, give heparin in order to prevent clots from forming on the wires or the balloon catheter which are on the left side of the heart. And therefore, you do this, then the left atrium, this wire is there. Then you take the 14 French mitral dilator and dilate the septum. And you dilate it, the septum go from below the right atrium across the wire into the left atrium. And once you have dilated enough, when there is no resistance for your dilatation, then you remove the dilator and takes the slenderized Inove balloon catheter and advance it into the LA. When you must see that in the lateral view, as it is shown in this picture, the needle punctures the intra-atrial septum, and the puff of contrast in the left atrium you can see that clearly identifies. Here they have given injection into the septum. You can see the the line of the septum. That is because they have given contrast when the needle is not yet punctured the intra-atrial septum. So what happens in the septal puncture? What are the various difficulties is in patients with mitral valve disease, the left atrium becomes large and the intra-atrial septum bulges into the right atrium. When it bulges into the right atrium, the fossa valis, which is normally between middle third and the lower third of the septum, is shifted down, and sometimes it is in the inferior third of the septum, and therefore it makes it difficult for you to engage with the catheter. When you are engaging, it slips up and accidentally you can puncture in the middle third of the septum, occasionally even the aortic. Therefore, you should be very careful. If this is happening, then you have to go back to the SVC and come back when you are still make slight anteroposterior motion of the broken barrow needle, and then that will help in engaging the limbic edge of the fossa valis. If that doesn't happen, then you give a slight curve to the needle, and that will help in engaging, and then you can puncture. Another difficult situation is when there is aortic valve disease, the aortic root is dilated. When you are coming down, it will jump directly from the aortic portion of the intra-atrial septum to the inferior portion near the AV groove, the intra-atrial septum, and there puncturing can be risky. It can cause pericardial effusion. Therefore, in that situation, always you have to take out the broken barrow needle, give a slight curve at the tip, and then you can engage in the limbic edge of the fossa valis and puncture. Another difficult situation is when there is a massive RA enlargement, as in patients with severe TR. In that situation, what you have to do is when you are coming down from the SVC, it comes freely into the RA cavity, doesn't abut the septum. Then you take out the broken barrow needle, 10 to 15 centimeters proximal to the tip of distal to the tip of the needle, give a curve to the needle, and then it abuts along the septum and you can puncture the intra-atrial septum. Most important complication of this procedure is cardiac perforation. You can perforate either near the coronary sinus or sometimes the free wall of the RA. And rarely when you have punctured already IAS, if you are too much advanced the broken barrow needle, you can puncture the posterior wall of the left atrium. So in experienced hands, the complications of septal puncture like perforation, etc., and tamponade are less than 1%, occasionally death of less than 0.5%. This is the Inove balloon assembly. You can see the assembly. This is the Inove balloon on the top, the metal stretching tube which will slenderize the balloon, and then you can see the left atrial wire, and then you have a syringe with 26 syringe, if you take, it will have markers like 26, 24, 22. You fill in the contrast. Suppose you want to dilate to 24, but make the contrast, inflate the balloon outside on the table and measure with the scale here that you have exactly 24 or not. Otherwise, take some more contrast and then make it exactly 24. So the amount of dilatation you want to give inside, you can measure outside. And then you have the stillet that will help you the balloon to direct into the across the mitral valve. So balloon, when you dilate, it dilates in 3 stages. First, the distal portion of the balloon dilates, then the proximal portion, and then the waist. The waist is the one that dilates the mitral valve. Balloon sizing, always effective balloon sizing is height in centimeters divided by 10 plus 10. So if somebody is 160 centimeter, the balloon size is 26. This is a well accepted formula for mitral valve dilatation. So crossing the mitral valve is probably the most difficult part. After you puncture, and then once the balloon catheter is in LA, it should be to the left of the pigtail catheter. If your pigtail catheter is still in LV, it should be to the left of the pigtail catheter. So here, slenderized balloon has gone across the infrared septum, and then you take out the steel tube, then you advance, take out the yellow tube, and then you advance the Mullin sheath. I know a balloon over the wire is little further, and then you take out the left atrial wire and introduce the stillet into the mitral valve, into the inner balloon. Once the stillet is introduced, you can see in a minute the stillet is being introduced, and once the stillet is introduced, then you have to give a counterclockwise twist, because the mitral valve is anterior. A counterclockwise twist to the inner balloon catheter till you get this bobbing motion. And the bobbing motion indicates that you are just above the mitral valve, and then you can cross into the mitral valve. How do you cross into mitral valve? You hold the stillet and advance the balloon. So here, this is trying to cross the mitral valve. So you can see in a minute it crosses. There are 2-3 attempts to cross the mitral valve here, and you can see here it is bobbing, and then when you advance, it has not yet gone across the mitral valve, and then you make it a little more counterclockwise, then it goes. Then you inflate the balloon, it should be free in the apex. It should not be caught in the cardia. It should be free in the LV cavity, and then you pull back to engage across the mitral valve, not engaged well, therefore not an effective dilatation. Then again you go back, and then you can see you cross again the mitral valve, and then inflate the distal end. Now it is engaged well, and you can see the inflation now. The distal end and the waist dilates the mitral valve, so it's very good. Once it is dilated, you can check the left atrial pressure. The drop in a left atrial pressure by more than 50%, and you have achieved. The stillet in the middle is the shape of the stillet, that is you have if you puncture around the fossa ovalis region. But if you puncture below the fossa ovalis, low puncture, then you have to make this U curve into a C curve. You have to pull it up so that you can go across the mitral valve. If you have done a high puncture, you have to make it more U curve so that you can go across the mitral valve. So it's very important that suppose if you go vertically down and then your balloon is caught in between the cardia and the mind, the tip of the balloon won't be free. If you inflate, it won't be free. It will be caught. In that situation, you do an accordion maneuver. Accordion maneuver is advance the stillet and come back with the balloon slightly inflated. Then it will come out of the cardia, go to the apex. Once it is free, do the mitral valvuloplasty. If you do it when in the cardia, you will rupture the cardia and there will be severe MR. Therefore, this precaution you have to take. And in patients with large left atrium, sometimes very difficult to enter the mitral valve. In that situation, you can do an opposite maneuver, which is called clockwise instead of counterclockwise rotation. Pull the stillet 10 to 15 centimeters across the intra-atrial septum, and then give a clockwise rotation to the stillet. Clockwise rotation leads the Mullins to the inner balloon to go posterior wall of the LA, and then you advance it, crosses the mitral valve like this. And when it crosses, you can pull it back and dilate. And sometimes when you have done a low atrial puncture, it is very difficult to cross into the mitral valve. In that situation, what you can do is you can take a multi-purpose catheter and a 3-2 wire, and then direct the multipurpose catheter in the 3-2 wire across the mitral valve into the LV, advance the Mullins sheath into the LV, and then pull out the multipurpose catheter in the wire and put the LA wire in the LV. So this is over the wire balloon mitral valvuloplasty. Over that, advance the mitral valve balloon and dilate the septum over the wire. This technique is done also in patients with left atrial appendage clot in order to prevent any embolic episode during the procedure. So this is how mitral dilatation is done. Whenever there is a complexity in crossing the mitral valve, that means a complex case. There is over risk of mitral regurgitation, also rare risk of perforation. So it's very important to shape the stellate accordingly, and the accordion maneuver is very important whenever the balloon is caught in between the cardiac. Always dilatation has to be stepwise. Start with -2. If the patient is 60 centimeter, 26 balloon is the maximum. Start with 24. And if the patient has a calcified or a valve or a very difficult valve, then go -4. You can go -4 and then stepwise increase the second dilatation 1 millimeter more, and the third dilatation another 1 millimeter more, and that's how you can dilate with the in-away balloon valvuloplasty. I think I have exceeded my time. The most important complication is mitral regurgitation, which can occur in 2 to 9% of the patient. It can be either due to overstretching of the mitral commissures, where the leaflets don't co-opt, or there can be rupture of the cardia or rupture of the anterior mitral lead, and that can cause severe mitral regurgitation, damage to the papillary muscle also. Same-day mitral valve replacement is required in 2% of patients. In skilled hands, the complications are 5%, and it is very important. Mortality is less than 1 to 3%, and hemopericardium, etc., is very rare. Systemic embolization is also rare.